All right, so today's talk is on the rate of and time to arthrodesis in long segment ACDF. Thank you for that great introduction, Dr. Chen. So before we begin, I did want to say that I do have no financial disclosures to declare regarding this presentation. I would like to acknowledge several of the neurosurgery staff at UVA, including both Dr. Shaffries, Dr. Buckles, Dr. Yen, as well as Dr. Smith for generating some of these patients and allowing me to use their data for this publication. So in terms of today's objectives, I think there's two real simple takeaways that we should be getting from this rather brief presentation. That's to appreciate the time to arthrodesis for individual cervical levels after a long segment ACDF, as well as appreciate that not all cervical levels fuse at the same rate or at the same paces. So in terms of the what and why of this presentation, specifically a long segment ACDF is defined in literature as anything greater than 3 or more adjacent segments. So this is 3, 4, and 5 level ACDFs. Why we were taking a look at this particular subset of patients at UVA was that there's been a varying rate of success in the literature, and some of the studies have had less than ideal quality in terms of follow-up or in terms of methodologies. As we know, our population is aging as well as becoming more active as they grow older, and degenerative disc disease is always a 1 or 2 level phenomenon that the ACDF was initially designed for. As such, 3 and 4 level ACDF procedures are more increasingly performed, including several that I've seen in the past 2 weeks, even here at Mayo Jacksonville. So I think the first and foremost question that we had for this project was how we actually determine fusion. And to this, we referred to a systematic review by Ashina and Rue et al. In 2018. They looked at all of the published methods for determining fusion in the literature and used a combination of objective metrics as well as professional opinion and experience to determine what they deemed as the best methodology, which we also agreed with. They did look at various individuals using CT as well as flexion and extension films, and they ultimately decided that the most reliable, the cheapest, the fastest, and the safest for the patient was looking at intraspinous distances on FlexX films with a 1 millimeter cutoff. And those are a lot of words for trying to describe something that's probably best described in a picture. So to sort of look at this, I have an example from our patient series for a 4 level ACDF. On the left, we see flexion. On the right, we see extension. And what we're doing is we're zooming in on the actual spinous processes themselves on the X-ray and finding a landmark that is identifiable on both flexion and extension to the reviewer. Upon finding that, a line is drawn from that level to the next level, another landmark found on the inferior or superior level, depending on which direction you're going, and a simple measurement of distance is taken. You then compare the measurement of those distances between flexion and extension. If the delta is less than 1 millimeter, this is considered fused. If the delta is greater than 1 millimeter, it is not fused. And here we can see that this is a rather successful 4 level fusion with good graft incorporation as well as very limited motion on flexion and extension. So in terms of the patients we were able to look at, this was drawn retrospectively over the course of 8 years. We were able to identify 66 total patients, about 2/3 of which were 3 level patients and 1/3 of which were 4 level patients. These were all patients that had at least 1 year of follow-up. They had no concomitant cervical surgery, so no anterior, posterior, anterior flips. And then they also had not had any sort of previous instrumentation in the cervical spine. Of note, some preoperative variables that we were concerned about causing confounding effects for fusion rates were relatively unchanged between the two groups. It should be noted that the 4 level patients were a little bit lighter in terms of weight, and this is probably due to a patient selection difference between the two groups. That is, a surgeon would not want to necessarily approach a rather obese patient with a rather in-depth and intensive long segment ACDF, a 4 segment specifically. But their smoking rates and osteoporosis were relatively comparable. In terms of the data, so what we're looking at here is a Kaplan-Meier survival analysis curve. And in this case, the time to event is the time to fusion. What I've done here is broken down the individual levels for each of the patients receiving 3 level ACDFs. And as soon as they are fused, they are marked as a positive. So that's an uptick on the y-axis. X-axis is, of course, time since operation, and you see that we have a substantial amount of follow-up between our patients. I think the takeaway from this graph, the two takeaways, is one, the superior segments fuse at a much higher rate than the inferior-most segment, the C6-7 level. In addition, previous dogma was that fusion took about 12 months, sometimes 18. When in reality, only about half the patients that would go on to fuse had fusion by 12 months. Whereas at 24 months, it was close to 90% that would actually go on to fuse, had already fused by that point in time. So again, looking at the 4-level patients, this is almost an exact carbon copy of the previous graph. And that's because the data are very similar. So for patients undergoing 4-level ACDFs, the fusion rates, the time to fusion, and the levels by which they fuse are nearly identical to the previous. Again, we see the superior levels fusing much higher rates than the inferior most, the C6-7 level, as well as about half the fusion occurring by 12 months and about 80% of it occurring by 24 months post-operatively. In terms of the limitations of our study, so of course it's retrospective in nature. We did get this across a broad spectrum of time, as well as several different surgeons contributing to this, but any retrospective study is inherently flawed. In addition, as we saw that about 80% of the fusion had occurred by 24 months, it was disappointing to see that only 70% of our patients had 24 months or more of follow-up. I mean, this is about the floor level in terms of fusion rates. The fusion rates could have been much higher, or I should say at least moderately higher, had more patients had 24 months of follow-up. Another fault of the study was that there was insufficient N for patients who had fusions that went down to C7T1. And the reason I bring that up is because, as you know, C6 and 7, they fuse at a much lower rate. We weren't able to determine if this was due to a biomechanical factor of C6-7, or if this is because they were the bottom of the construct. If we had more patients that had the bottom of the construct being C7T1, this would have allowed us to control for this confounder. In addition, what we did not do was control by checking the patients who had single or dual level ACDFs during this time that also had C6 and 7 involvement, to check if this was a long segment effect or just a sort of artifact of C6-7. And then last, we did not control for any minor differences between surgical techniques across all of our contributing surgeons. In terms of the conclusions I think that you can make from this study is that 3 and 4 level ACDFs are both capable of creating arthrodesis at all instrumented levels. Obviously C6-7 less so, but the remaining levels are almost guaranteed to fuse. The majority of fusions do occur within 2 years post-operatively, and then about fewer than half of the patients that will go on to fuse have their fusion by 1 year post-operatively. And then, like I said, C6-7 just didn't seem to fuse. So I think the takeaways for neurosurgeons is that the ISD method is both fast, cheap, reliable, and it is relatively easy with high levels of inter and intra-rater reliability to determine fusion. Patients should be followed for a minimum of 2 years if there is concern for pseudoarthrosis after a long segment ACDF. And I think it's also important to a priori set reasonable expectations for both yourself and the patient regarding C6-7 fusion rates. So at that, I will appreciate your questions, and I thank you very much for your time and attention.
Well, thank you very much, Jesse. Actually, a very interesting presentation. You know, you're right in that a lot of us just assume that 1 year mark, if a patient's going to fuse, they will have fused by 1 year. But clearly, your study shows that at least in long segment fusions, it can take up to 2 or more years. My question for you, when you follow the patients out, you know, beyond 2 years, so, you know, looking at your Kaplan-Meier curve, the denominator that you're using, is that all patients that you were able to follow out to 72 months, or how did you determine the denominator, I guess, in terms of determining the percent fused?
Yeah, that's a very good question. So that was part of the methodology, was that I wanted to make sure that once a fusion occurred, that level stayed fused. So I followed my patients as long as we had imaging for. The mean follow-up time was over 48 months. But essentially, once a patient was fused, there was no evidence I could find that fusion became unfused, so to speak. There was no evidence that once someone had a less than 1 millimeter motion on FlexX, they suddenly had more than 1 millimeter later on. As such, this is essentially a sort of time to event curve, since there was no regression of those events. So the denominator was the entire population that had follow-up for at that point in time.
Gotcha. Okay. And one other question I had, you mentioned about differences in surgical technique from surgeon to surgeon. Were the grafts used identical throughout the patient cohort? The example you showed it looked like cadaver allograft. Were there any patients that used, or the surgeons used cages or cellular allograft, or how did you look into that?
Yeah, that is a very good question. Fortunately, that was one of the things that every surgeon did very similarly. So they all had cadaveric grafts rather. We did not use any cages, any PEEK materials such as that. So this was what we're talking about was mainly post-operatively. I found that some surgeons did bracing, some did not. and then some applied varying levels of traction, whereas others did not. But in terms of the actual materials themselves and the arthrodesis, that remained consistent across surgeons as well as time.
Okay, great. That's actually somewhat unusual in this day and age with the varied techniques for ACDF. So I'll start with the Dr. Miller. I think he had his hand up first. Dr. Miller.
Sorry, I couldn't get my microphone. Yeah, no, interesting presentation. And I got called out a little bit in the middle of it. Just one comment, and not to, please don't take this really coming from me as a criticism, but you might want to mention if you present this, and I think this is worthy of presenting at a wider audience, you might not suggest that retrospective studies are inherently flawed, maybe just say they have limits. Because actually you can get some great data from retrospective studies, just it depends on what, but there are certain things you can't get out of them. But I, as I said, I think it's a well done study and very interesting conclusions. My question is, with you as your pharmacy degree background, are there things that you see that can be done medically to aid in the fusion rates, things that you think can be done? Or there medicines coming down the pike, or things that you know of that you have seen be helpful, or you think can be helpful?
I haven't actually looked too much in the pharmaceutical aspect of it, ironically enough. That's a great point. I didn't control for any sort of perioperative or post-operative medications that could impact fusion. I do believe that one of the surgeons was using tranexamic acid post-operatively, whereas others were not. And I think that was only in a few of his cases, though. And to be honest, I until just now, I didn't really think to actually verify to see if that impacted his fusion rates by any meaningful margin. I think, unfortunately, the sample size was so low with that gentleman in his cases that I don't think any of the data would have been relevant.
Yeah, but it's I think certainly with your background and your abilities, that's an interesting tack to take. And if you can, especially being at UVA and here, if you can get numbers out of it, it would be interesting, I think, to see if there's any trend that way, and thoughts for future studies that you could do.
That's a great point. I'll have to review that and see what I can find. I appreciate that.
Great presentation. Thank you.
Great. I think Olu is next.
Thanks, Jesse. Good talk. A couple quick questions. So one, were any of the patients that didn't fuse at, say, 2 years, 3 years, were they symptomatic from that? And was there a true pseudo with haloing of any of the screws? And second question, so in the Kaplan-Meier curve you gave, I saw, for example, some of them didn't have fusion until like 72 months out. My question is, did all the patients receive x-rays at the similar intervals? Because, for example, if a patient doesn't receive x-rays until 2 years out, then it will show that, okay, they fused at 2 years out, but maybe they didn't have imaging before then. So was that kind of controlled in any fashion?
No, you're absolutely correct. That is something that was a result of using that analysis. Was if a patient was seen at 3 months and had no fusion, but then was seen at 72 months, like you astutely pointed out, they likely fused much before 72 months, probably closer to the 2 year mark. But because we didn't have any data for it, we had to mark them as a 72-month fusion. In regards to controlling for that, largely our surgeons followed a 3, 6, 9, 12 approach, and then 24 afterwards in terms of month follow-up, but that was not always maintained, unfortunately. If I would have looked at only the patients that had 12 and 24-month follow-up films, I probably would have had only maybe 20 or 30 patients to look at, and I'm not sure if our analysis would have been quite robust. So that is one detraction, is that essentially we're looking at floor values for fusion, since not everyone had 24 months of follow-up. In addition, we're only looking at, we also have a slightly longer time to fusion on average, because there were patients that had very wide gaps between their initial follow-ups and final follow-ups.
And then for the first question, were any of the patients symptomatic, or were there like true pseudo?
Yes. So that is one of the, I think maybe the detractions of this methodology for fusion, is that it is a highly sensitive but not specific method to determine if fusion or if pseudoarthrosis has occurred. Our revision rates were only about at like 10 to 20% across these two groups. I have it listed here on the slide. So people were not terribly symptomatic if they were not fused. So if you look at any one level patient, you would expect maybe 70% of them would have all 3 levels fused for 3-level, and only about 30 to 40% for 4-level. And yet, despite that, we're having 6 and 16% revisions respectively, with over 4 years of follow-up time. So I do think that is one flaw in the methodology, is that it is very sensitive to pick up non-union that may not be clinically relevant.
Okay, thank you.
Of course.
Great. And then we'll take one more question from Dr. Buchanan.
Hey, Jesse, great presentation. I had a quick question. There's a recent paper, or maybe about a year ago, by the same senior author on the systematic review that you presented, which they showed that the pseudoarthrosis rates are correlated with the length of the screw in terms of the anterior posterior dimension of the body, right? So the longer a screw you place, the less the pseudoarthrosis rates. Even within the same surgeon, unless you consistently try to get bicortical screws or as long a screw as possible, there's huge variation. So the picture you showed, for example, is only about 75% coverage in terms of the AP distance to that body. Was there any attempt made to control for that, especially because there are multiple providers?
No, and I appreciate you bringing that up. This was published and performed in 2018. So that this would have been published before Ken Rue's manuscript, unfortunately, his latest manuscript, I should say. So no, we did not control for screw length whatsoever, or I guess percent depth as a better term for pseudoarthrosis rates.
Got it. Okay.
Appreciate it. That's interesting to look at. I'll have to look at that paper. Thank you.
Well, great, Jesse. Excellent talk. So thank you very much. And finally, we have Rohan, who is visiting us from the mothership up in Rochester. He is with your medical student, and he will be talking to us about outcomes of epilepsy surgery in the older population. Not too old, not too late.
All right, thank you for the warm welcome. Yeah, I'm from Arizona.
Oh, sorry, apologize. Yeah, it's warmer weather, similar here.
Another satellite branch. Okay, so yeah, I'm presenting on the surgical outcomes of epilepsy surgery in the older population, not too old, not too late, which I did with my co-authors up at the mothership, Dr. Van Gompel, Dr. Miller, Panos, and others. So a little bit of background. Hospitalizations due to epilepsy in patients 45 and older have been increasing over the last 2 decades, which, some people could say maybe it's just because we're documenting better with the EMRs or due to an aging population. But either way, we know that there's a lot of epilepsy in patients 45 and older. Level 1 evidence has established that surgery is a safe and effective option for medically refractory epilepsy. But the existing literature has focused primarily on the younger populations, and the efficacy of epilepsy surgery in older patients has not been firmly established. So the goal of our study was 3-pronged. First, we wanted to evaluate seizure freedom rates and postoperative outcomes in older epilepsy patients who underwent surgery from 2002 to 2018 at our institution. The second goal was to perform a meta-analysis to compare our results to the known outcomes in the literature. And the third goal was to analyze the complication and mortality rates of epilepsy surgery in the elderly from a nationwide administrative database. So our methods for data source and patient selection, we looked at our electronic database for patients who underwent open surgery for a primary diagnosis of focal or generalized epilepsy. Only patients 50 years or older were included. Time frame was 2002 to 2018. And then we grouped the patients in categories based off their age. So 50 to 59, 60 to 69, and 70 up. The outcomes and covariates of interest. So the primary outcome of interest was seizure freedom at the last follow-up of at least 12 months. Seizure freedom was defined based on the International League Against Epilepsy Class 1 and 2 outcomes. Secondary outcomes of interest were the length of stay, the postoperative complications, and neurocognitive outcomes. statistical analysis. So medians with interquartile ranges and frequencies with proportions were used to summarize continuous and categorical variables respectively. Variables were compared using Wilcoxon rank sum and Pearson's chi-square test with respect to seizure freedom. For literature review, we followed the standard PRISMA guidelines for all literature up to December 2020. We excluded case reports, abstracts, papers on English. Seizure freedom complication rates were meta-analyzed based off the Durasimonian layered random effects model. And then for the national database, we used the Vizient database, which is the largest member-driven healthcare performance improvement company in the US. It has patient level and hospital level billing data from academic institutions and their affiliated hospitals with regard to illness severity, the utilization of medical and surgical interventions, complications, and third-day readmissions. And we queried this database using ICD-10 codes. So our results for our institutional series, we had 73 total patients, about a 2-to-1 female to male split. 16 patients were in the 50 to 59 age group. Most of the patients, 47 total patients, were in the 60 to 69 age group, and we had 10 patients that were 70 or older. This is kind of a large table. It's a very numbers heavy paper, but this is kind of breaking down the seizure workup. And this p-values is comparing if there's any difference across all the age groups. So the age of first seizure was pretty comparable across all age groups, about middle age. Epilepsy duration was also pretty comparable, somewhere between 10 to 20 years. There was no difference that we found in the type of epilepsy among the different age groups. And we didn't find any epilepsy syndromes in our cohort at all. Number of seizures per month. So that did vary based off age group. So the 50 to 59 age group had the most seizures per month at 10.5, compared to the average for all age groups was around 4. There's no real difference in the number of anti-seizure medications across age groups, and no real difference in prior epilepsy surgeries. So surgery type and pathology. So the most common was intratemporal lobectomy and selective amygdala hypocampectomy, followed by lesionectomy and frontal lobectomy. There's no real difference that we found in the type of surgery that patients got based off of age. Most common pathology we found was gliosis, followed by mesial temporal sclerosis. And again, there was no difference in the type of pathology that we found based off age group. Postoperative outcomes. So seizure freedom rates were pretty good, around 70% for the entire cohort. It didn't vary. It wasn't statistically significant across age groups. Length of stay was about 4 days, pretty much across the board. Number of anti-seizure medications that last follow-up didn't differ across age groups. We did find that about a third of patients did have a decrease in the number of anti-seizure medications that they had to take at last follow-up, but it wasn't significant across age groups. In terms of the neurocognitive outcomes, which is kind of not talked about as much in the epilepsy literature, we found that about 67% of our cohort were stable. Around 8% actually had improved neurocognitive outcomes, but we did have around 25% that had worse neurocognitive outcomes. One kind of issue with this is that there was no formal testing done for the neurocognitive outcomes. It was just kind of based off what the patient and the family reported. So I think that's definitely an area of future study. In terms of postoperative complications, our cohort had a 0% mortality rate. Permanent neurological deficits were only seen in 5 patients, 2 hemiparesis, 2 anomia or expressive aphasia, and 1 stroke leading to vision loss. And then we did have some temporary deficits, visual field deficits, surgical site infections, and some related readmissions. onto the literature review and meta-analysis. So we queried several different databases, and we found 15 studies that were included for the meta-analysis. And here's kind of an interesting graph kind of breaking down where these studies are coming from. Most of them are from North America, a couple from Europe, a couple from Asia, one from Australia, one from South America. The seizure freedom rates across all these studies were pretty comparable. In total, for the literature review, there were 474 patients, pretty even male to female split. Mean age at surgery was 56.9 years. Mean follow-up was 39 months. And anterior temporal lobectomy was the most common procedure, similar to what we had at our institution. Mesial temporal sclerosis was the most commonly seen pathology. And we did multiple variable meta-regression analysis to find variables associated with higher rates of seizure freedom. The only two things we found was actually the mean age at surgery. So older age was associated with higher degrees of seizure freedom, as well as the presence of mesial temporal sclerosis was associated with higher rates of seizure freedom. And finally, we looked at the nationwide outcomes from the Vizient database. And with this, we looked at 18 to 49 and we compared it to the age groups that we had in our study. So one thing you can see is there's about 2,000 patients in the 18 to 49 compared to maybe 600 or so, 15 up. So older patients just are not getting surgery for epilepsy as much. Length of stay, you can see that it does increase with increased age. So it starts at 5.3, then 6.2, 7.3, up to 12 in the 17 up group. Mortality similarly has this trend. 18 to 49 group has a 0.2% mortality rate, which increases to 10% in the 17 up group. Cases with at least one complication follow a similar trend, less complications in the younger population, more in the older population. One issue is that we're not able to decipher what these complications are, if they're temporary or permanent, what the severity is. It's just kind of listed as complications in the database. So discussion on safety. Complication rates at our institution were very low. Majority of complications were transient, didn't necessitate any urgent surgical intervention. Complications in the nationwide database ranged from 4.7 to 17%. But again, there was a lack of reporting on what these complications really were. Mortality rate at our institution was 0%, whereas in the nationwide database, it ranged from 0.5 to 10%. But we're unable to determine what the precise cause of death is in these cases. In terms of efficacy, seizure freedom rates were high at our institution at 73%, and they were actually slightly higher than the cumulative rates reported in the literature at 65%. Seizure freedom rates didn't differ significantly across age groups in our cohort, but in the meta-analysis, we did find that age at surgery positively correlated with seizure freedom. And neurocognitive outcomes. Up to 75% of patients experienced stable or improved neurocognitive outcomes. But like I said previously, there was a lack of formal testing in most cases. So we're reliant on the patients and caretakers, kind of saying this to the doctor who's going to put it in the notes. And then I go and do a chart review. So it's a giant game of telephone. I think this is definitely something that we should prospectively analyze and set up a real formal way to analyze this. And there's a real lack of consistent reporting in the literature, so we weren't even able to do a meta-analysis on this topic. So it's definitely an area that warrants future investigation. So the key points, seizure freedom rates are high at 73%. Our institution was higher than that reported in the literature, so go us. Age at surgery and presence of mesial temporal sclerosis positively correlated with seizure freedom. In our institutional cohort, mortality and complication rates were low. From the nationwide database, both mortality and complication rates were low, but it did increase with age. So if there's one key takeaway, it's that the age should not preclude anyone from surgery. They should be, totally worked up to understand the entire clinical picture. And thank you.
Well, a great talk, Rohan. So it's actually very interesting because probably people who are outside the epilepsy community will think that once you reach a certain age, you don't necessarily qualify for epilepsy surgery. But it seems like this study basically goes against that preconceived notion.
Yeah, exactly.
Yeah. So one question for you: did you look at any subgroup analysis within each particular age subset to see if there were other factors that correlated positively with seizure-free outcome? So I know you mentioned presence of mesial temporal sclerosis, but other medical comorbidities that may have positively or negatively correlated with seizure freedom, anything along those lines?
No, outside of kind of the general pathologies that we found that we looked at, like tumor, vascular abnormalities, we didn't look at any other medical comorbidities.
Okay. Well, anyone else have any other questions? Dr. Graywall sends his apologies. He had to run to the OR, so he's our epilepsy surgical expert. He's not here to ask any questions, but anyone else have any questions or comments? All right, great. Well, I want to thank all of our visiting medical students and all of our speakers, Eduardo, Jesse, and Rohan. Excellent presentations. We'll look forward to more medical student presentations in the coming weeks. This upcoming Monday, we do have our own resident, Dr. Christian Ravindran, speaking on a middle meningeal artery embolization for chronic subdural hematoma as part of our Monday morning lecture series. So please join us for that. Otherwise, everyone enjoy your Fridays and have a great weekend. Bye.
Thanks all.